Hello guys, am I audible and visible? Hope I am. Just give me a second. So we are in the study with me session of third one for today, right? Just give me a second. Good evening, Debraj. So in the third thing about study with me session, where we are going to discuss about few WBC editions, right? So we might have a few MCQs at the end, right? So if time permits. So our main goal for today's class is going to be about WBC disorders. Just give me a second. Fine. So WBC is one thing. Hello Samir. WBC is one thing which is required for whatever exam you write, right? Let it be INECT, let it be NEET PG or an FMGE exam. WBC is one where most of the MCQs come on, right? So especially the lymphoma and leukemia and the CD markers. Okay. So I wanted to discuss about this for a longer time. I'm going to name it a B-cells journey. We're going to look at the entire B-cells journey. No, Debraj, I'll do it. Right, getting a bit caught up in plus classes. I'll definitely do it. I'll just put a schedule for you again, and we'll continue it for sure. Okay. Fine. Sorry, it's loading a bit. Just give me some second. We're going to discuss about something called your B-cells journey, right? Because here I want to take some time and discuss about the WBC neoplasms, the CD markers especially. For knowing the CD markers, I have to know a little bit about the basics, and we are going to do everything about the basics here. So there will be two sessions on WBC. One will be today, the other will be tomorrow, and after that we'll have a quiz in the Unacademy app, and hopefully if you top the quiz, you might get 5,000, 3,000, 2,000 was gift voucher. Fine. Okay, these are the prices which will be available for you guys if you attend the 20 MCQ session after the 4 classes of YouTube session. Fine. Tomorrow at 5 p.m. we'll be looking at the lymphomas. So today I'm going to just talk about normal things in WBC. I'm not going to talk about anything abnormal. Once we understand normal, we can easily extrapolate to many abnormality. Fine. This might not be an easy session. See, some things when you read something very easy, you are not going to retain it for long. I am a strong believer of that. You put hard work, you will definitely retain it for a longer time. Fine. So this might be a bit, I won't say very difficult. It's very basic. So I want a little bit of patience from you. So if you have any doubts in between, you can ask me. I will ask questions as well. I want you to answer these questions as well. And these questions is going to be very, very easy. Fine. So we're going to name them as B-cells journey. So the normal B-cell, what they're going to do when they come into a lymph node, that's what I'm going to learn as a B-cell journey. So a B lymphocyte will undoubtedly come into a lymph node, and it might stay there in the lymph node, or it might go away from the lymph node, right? These are the few things what a B-cell does. So we'll be seeing 3 scenarios. A B-cell without exposure to an antigen, what they're going to do once they come into a lymph node, the first scenario. The second scenario, a B-cell after getting exposed to a self-antigen, because B-cell can get exposed to self-antigen as well, right? What they're going to do is the second scenario. The third scenario, a B cell after getting exposed to a pathogenic antigen like streptococcus or staphylococcus, what is their route is the third scenario here. To understand that, I need to know a little bit about basics about a lymph node. If I know a normal lymph node, I can easily extrapolate to say, okay, this is what happens when it's abnormal, right? So a lymph node has cortex and medulla, right? Does a lymph node have a capsule? I'm just going to talk about a normal lymph node. Will a normal lymph node have a capsule or not? I do want answers. It's completely fine if it's wrong. Lymph nodes do have a capsule, right? So let's assume there's a lymph node, completely normal surrounded lymph node, and obviously every lymph node will have a capsule. In the capsule place is where all the lymphatics will come inside, right? Your afferent lymphatics comes inside via capsule, right? This is my afferent lymphatics. So if it is going to drain my tonsillar fossa, the jugular-digastric node, the draining part comes via the lymphatics. And below the lymphatics, below the capsule, I have a structure called as a subcapsular sinus. Fine. We have something called as a subcapsular sinus. So once it goes inside, the lymphocytes, the afferent lymphatics is nothing but the lymphocytes come via this, right? You can gain inside here. Here I have cortex. In cortex I have follicles, interfollicular area, and then I have medulla. The only function of medulla is it will take all the blood vessels and my efferent lymphatics, and the efferent lymphatics goes via the hilum, right? This is completely normal. So I'm going to ask you a few more questions, leading questions here. It's a lymph nodes follicle. What will they have? B lymphocytes or T lymphocytes? Hi Devapriya. A lymph nodes follicle will have B lymphocytes or T lymphocytes? They will have B cells, right? A follicle is predominantly made of B cells. The interfollicular area is predominantly made of T cells. Okay? This is like an overview of how a lymphocyte is going to look like. Fine. So as I said that we are going to have three things here: my normal, without exposure to antigen, with exposure to antigen, and other one. Right? Great. So now let's assume that. Let's see what will happen to a naive B cell. Right? A naive B cell. When I call something a naive B cell, these are the B cell with exposure to antigen or without exposure to antigen. These are B cells without exposure to antigen, right? So every naive B cell in my body, whatever is there in my circulation, all of them are naive B cells, right? Yes, Debraj, I can see your comments. Fine. A naive B cell is one without exposure to antigen, right? So all the naive B cells in my body will have CD5 and CD23, right? I think you asked the same question here, right? So CD5 and CD23 are actually present in a naive B cell. Though 5 is a T cell marker, it will be present by B cell also. I'll tell you the function of these two. CD5 is going to help in the proliferation of B lymphocytes. It helps in the multiplication or proliferation of B lymphocytes. CD5 has one more role. If CD5 is present, a B cell cannot enter a germinal center, right? It's like ticket. If it is absent only, it will enter a germinal center, right? If it is present, it can't enter germinal center. That's the thing here. For CD23, there's only one function. If CD23 is present, a cell cannot enter the inner mantle zone, right? It can't enter my inner mantle zone. Okay? It will not be able to enter an inner mantle zone. That's what happens to my CD23, right? Hopefully the charge stays for long. Okay? So in other words, if whenever my cell gets exposed to a subthreshold stimulus or a self-antigen, CD23 will be gone. Whenever my cell gets exposed to my pathogenic antigen, streptococcus, CD5 will be gone, right? Then they can enter my germinal center, right? So let's see a first look about what will happen when a naive B cell enters. My naive B cell will enter my afferent lymphatics. Once I enter afferent lymphatics, I'll have macrophages here in my subcapsular sinus. I'm writing SCS for subcapsular sinus. So it's not having any antigen, so it will not interact with my macrophages, right? Once they don't interact with my macrophages, it goes inside again. It goes inside. Let's assume this is my follicle, my germinal center. I have something called as an outer mantle zone. Yeah, outer mantle, and I have something called as an inner mantle. I have written dotted lines in inner mantle, right? It is not exposed to anything. It's a naive B cell. So what will happen is they cannot go into the inner mantle because they have 23, right? So what happens to an naive B cell here is they'll come here, they'll go to the outer mantle, they go outside, and they escape into my medulla. Once they go to the medulla, automatically they're going to go outside the entire cell itself, right? Outside the entire lymph node, right? It exits in from a lymph node, right? This is the normal routine of a naive B cell. Got this? If you have any doubt in any point of time here, I want you to ask, because these are things which I wish that everyone would have known before starting an understanding about WBC neoplasms. Fine. Okay. I'll come. Don't worry. Fine. So the second thing what I'm going to see is I'm going to see a B cell getting exposed to an self-antigen. We're going to see what will happen to a B cell after it gets exposed to self-antigen. Just a second. Sorry. Give me a second. Sorry. Yes, Ankit, I'll do it. Right? Sorry for the glitch. It came back again. Right? So I'm going to have a B cell after getting exposed to self-antigen. What's going to happen is what we're going to see next. Fine. So to understand this, we'll come and have a look at mantle zone. See, Sanket, when you have a follicle, a secondary follicle will have germinal center. That's the first important layer. Outside this, I'll have few lymphocytes. These lymphocytes zone is called as a mantle zone. Mantle is just a lining, right? Beyond this, I have a zone of lymphocytes. I'm going to call this a marginal zone. what is going to be present in the marginal zone is I'm going to have nothing but a memory B cell, right? A memory B cell will be in the marginal zone. The second one, I have a mantle zone, and then I have a perfect germinal center. These are the three layers what I'm going to have in any lymphoid follicle, right? It's just the outer covering, that's all. So once an antigen B cell gets exposed to self antigen, we'll come back to it again. It has got exposed to self antigen. Once it has got exposed to self antigen, am I right in saying that this antigen will be processed by the subcapsular sinus macrophage? Because macrophage has two roles. One is phagocytosis, the other one is processing an antigen, right? Antigen processing cell. So once they go into my afferent lymphatics, my antigen presenting cell or the macrophage will process it. Once an antigen presenting cell process anything, who will they present to? B lymphocytes or T lymphocytes? They'll present this to my T cells. So once my antigen presenting cell process something, or once an antigen is bound to a B cell, whatever may be the antigen, my CD23 will be lost. That's what is going to happen to the cell. If CD23 is lost, can they enter the inner mantle zone? They can. I have a germinal center, so I had an outer mantle. They came inside, it can enter the inner mantle zone as well, right? So once they enter the inner mantle zone, okay, so the inner mantle zone, once they enter, I'm going to have one more thing which is going to be turned on, which is cyclin D1. Because now my body is thinking that this B cell has to proliferate, has to produce antibodies, right? So once they enter the intermantle zone, cyclin D1 will be activated. But by this time, my T cells will know that this is a self antigen, because T cells know it is self or non-cells. It knows it's self antigen. Once it knows self antigen, should I let them enter my germinal center or should I kick them outside? I should kick them outside, right? Because if I make them enter the germinal center, I'll have antibody production against a self antigen. I should not make them happen. So I'm going to kick them outside. Once I kick them outside, it's again, once there's no self antigen, my CD5 will still be present. It's going to come here. It cannot enter, right? Because once it enters germinal center, for that to enter, my CD5 should be lost. So what's going to happen? Any B cell getting exposed self antigen will again come outside, will go to the medulla, it'll go to the medulla and it exits the lymph node, fine. I'll just have a quick look of whatever I said again, we'll recap it. I'm having a B cell getting exposed to a self antigen. Once it gets exposed to self antigen, my CD23 is gone. The antigen will be processed, given to T cell, because macrophage cannot identify self or non-cells, T cells can identify. By the time T cells is identifying that, these B cells went into my inner mantle zone because my CD23 is lost. Once it goes inside, my cyclin D1 again produces, because hoping that it will enter into the germinal center. Cyclin D1 is it converts from G1 to S phase. I'm just making the raw materials ready, right? So by the time T cells will know that, see, this is not a pathogenic antigen, it's a self antigen, retain CD5. If it's a pathogenic antigen, CD5 will be gone. If CD5 is retained, they can't enter my germinal center, it will go outside, it will exit, right? This is what happens for a self antigen. Now we'll come to a more important thing. I'm having a B cell with exposed to an pathogenic antigen. What will happen when I'm going to have a B cell exposed to a pathogen? Fine. It could be just T helper cells. T helper cells can also identify it. When I say T regulatory cells, they have different molecules present. T helper cells can produce CTLA4 and PD1 and can stop every process. The same like my allergy, right? They need not be T regulatory cells always. Okay. So it's got exposed to a pathogenic antigen. It came inside. My macrophage identified them. Once my macrophage identified them, it presented to my T cells. T cells know it's pathogenic. So what they're going to do is, they're going to make sure the CD5 is lost. If it's a pathogenic antigen, CD5 will be lost, right? Again, when they bound to an antigen, CD23 is lost, right? Okay. So again, I have the same germinal center, outer mantle, inner mantle, right? They came inside here. Once they came inside here, can they enter the germinal center? Because cyclin D1 is again already present here. Plus at the same time, my CD5 is also lost. Like loss of CD5 is a ticket for me to enter my germinal center, right? So it can now enter the germinal center. It cannot cross this barrier, exactly that place, if they have CD5. They don't have CD5, they can enter my germinal center, right? So now it's enter my germinal center. Now it's where I'm having a pathogenic antigen, I have to function, right? So to function, I need many things to happen, right? I have multiple clones. You must have heard about something called an epitope. Let's take that this pathogenic antigen, what I'm reading here is an streptococcus. It's just a streptococcus. and let's say there are 5 epitopes here. We know that epitope is an actionable site of any bacteria or anything, right? So am I right in saying that my body should produce an antibody for every epitope here, then whatever is the perfect match, I should produce them more so that I can destroy my streptococcus. That's my ultimate role, right? So what's going to happen is once they enter inside, I'll have a person called as the first lineage called as centroblast. Okay, that's my first lineage called as centroblast. So what's going to happen in centroblast is just a second. I just need to reduce my thing. Fine. So what's going to happen in centroblast is once you have centroblast, the main role here is to make sure it can produce multiple clones. It's going to produce multiple clones of B cells against all 5 possible epitopes. We just took an example of 5. All 5 possible epitopes, they'll produce multiple clones. So as I said that only one clone should be successful, right? So can I say that all the other clones should die? One clone will be a perfect match. I am in search of the perfect match. So can I say that all the other clones should die? It should die, right? So if I have to kill 4 other clones, only one clone is going to be a perfect match. What should happen to BCL2? BCL2 should be present or absent? What is BCL2? BCL2 is an anti-apoptotic factor, right? So if BCL2 is present, the 4 clones will not die. So BCL2 should be absent in the centroblast lineage, right? So I'm just going to look at the profile of the centroblast, that's all. They are CD19 positive, 20 positive for sure, right? They will be CD5 negative, 23 negative, because only when both are negative they can enter my germinal center. So here my BCL2 should be absent. It should be absent, right? Because BCL2 is anti-apoptotic. If it is absent, only then I can destroy 4 clones. These 4 clones should die. If they are present, I cannot survive, right? The 4 clones should die. It's completely fine, Sanket. So the 4 clones should die. So BCL2 is absent. Okay. So here, am I right in saying that when I am producing each clone, I will create some genetic change or genetic alteration? It's like a number lock. I produce different types of number lock. I will have to change genetic change, right? So can I call this as a mutation? Can I call any genetic change here as mutation? Is that correct to call it the mutation? It is. In your microbiology, you must have read something called as in somatic hypermutation or an VDJ recombination. You must have heard these terms, right? This is an somatic hypermutation. So it's a mutation. If a mutation is going to happen, who will come up and say, I'm going to protect these persons? There's one gene who's going to protect everyone. P53, right? Anywhere I have mutation, P53 will come and make sure it will correct all the mutations, right? If it corrects all the mutation, can I create the 5 different clones? I cannot. So am I right in saying that in the centroblast lineage, when I'm going to try miss and match error-based mechanism, I should not have P53, right? If my P53 is there, nothing of this will be possible, right? So what my body is going to do is going to suppress P53. It has to suppress P53, otherwise this perfect combination will be never formed, right? So to suppress P53, I have 2 guys. BCL6 will be present here. The other one is CD10 that will be present here. These both BCL6 and CD10 are transcriptional suppressors. These guys are going to suppress my transcription of P53. Okay. So this cell, the centroblast, it's an immature cell or a mature cell? It's an immature cell or a mature cell? It is an immature cell, right? An immature cell should proliferate a lot. For proliferation, I need one more gene called as MYC, because MYC helps in proliferation of all these cells. So centroblast again will have MYC gene. Okay, it's going to help in lots of proliferation, right? The c-MYC, we'll come to that soon. We'll link them all to cancers. I'm going to have c-MYC here. These are immature cells. They proliferate a lot. For proliferation, I need MYC gene, right? So these are the immunoprofile of a centroblast. So the only goal of centroblast here is Again, this is my germinal center. This was my outer mantle. Just a second, sorry. This is my outer mantle, my inner mantle. It came here. In entire this area, I'm going to have centroblast. So with all these permutation combination, what I found was a single perfect match. I was looking for this person and I found this perfect match. So this perfect match will mature and become a plasma cell, and I'm going to produce antibodies, perfect antibodies, a specific antibodies which can destroy my streptococcus, right? So let's say that it's going to mature. When a cell matures, what do I call them? From blast, we change the terminology. What do I call them? Whenever a cell matures, we call them a site, right? So I'm going to call them Centroside. So the Centroside, anywhere in the RBC or WBC lineage, when a cell matures, what do you think will happen to the nucleus? The nucleus will become smaller or the nucleus will become bigger? Especially in the WBC lineage, my myeloblast was there. It became smaller, shrunk and became my lobed neutrophil, right? So whenever a cell matures, the nucleus should shrink. The nucleus will get folded, right? So what's going to happen is, I'm going to have a cell. The blast was a high NC ratio. Here my cell will be folded nuclei. Okay. It will become folded. It will become smaller. Perfect. My cytoplasm will increase a bit. See, we'll try to link almost everything here. This nuclei is how the follicular lymphoma nuclei will look, because follicular lymphoma comes from my centrocyte. Okay, there's one more tumor which comes from centrocyte. I'll draw the nuclei. I'm sure you'll be able to remember it. We had a nucleus, a cell nuclei like this. Which nuclei is that? What comes to your mind? It's just an irregular nuclear membrane. What comes to your mind looking at this image? I'm sure at least one thing should come to your mind. Does it look like a popcorn? NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma, comes from the centrocyte lineage. So whatever comes from my centrocyte lineage will have an irregular cleaved nuclear membrane. So in a follicular lymphoma, I don't call it a popcorn. In NLPHL, I do call it a popcorn. The origin is more important. If it comes from that, it will resemble that only. Now let's say that this centrocyte, we look at how they will look. Fine. How the centrocyte is going to look morphologically, we know. How they are going to look immunophenotype wise. So my goal here with the centrocyte is to maintain the population. It's the perfect match. I cannot let this centrocyte die. I'm sure you'll agree with that. So if I should not let them die, which gene should I turn on? Which gene do you think I should turn on? I should turn on BCL2. Because once BCL2 is there, my cells don't die. They remain for a longer time, right? My BCL2 should be on here. So second thing, so which means it will not die. It persists. It should just persist. They should not produce antibody, right? Only in plasma cells should produce antibody. There should be no antibody production here, but they should persist. There's no antibody production. Again, I need to suppress my antibody production. For that, I need my BCL6, CD10. If you remember, these two are the markers. We used to call them germinal center markers. It is present in the centrocyte. At the same time, it's present in my centroblast lineage also, right? It's present in both places. They are suppressors. This is going to suppress my antibody production here. That's all. So my centrocyte will look bit of a more cytoplasm, bit shrunken nuclei, irregular nuclear membrane, and it will have a very less proliferation, because here I need not proliferate. I just have to maintain the clone. Very less proliferation, right? So with this, my germinal center gets over. After this, it comes outside. That's my post-germinal center. Okay, it's post-germinal center. When I say it's post-germinal center, I'll just push up a little bit maybe. So once it comes outside the post-germinal center, the only role here is to produce plasma cells, to produce antibodies, right? They came outside. I have two goals here. Should I need a memory here? Is it must for me to have a memory? I do need a memory, right? Without memory, I cannot have a heightened immune response next time, right? So once it comes outside, I have few possibilities here. One, it becomes a subset of them becomes memory B cell. The memory B cell goes back to my marginal zone and they stay there. So once it goes back to my marginal zone, this memory B cell should live forever, at least for few years, so that I can have a heightened memory. Vaccines work based on that, right? So to live for a longer time, I add one more molecule here called CD43. All these are proteins. This CD43 will be turned on in a memory B cell so that they can live for years together. They are going to be dormant. They don't do any function. They just live. Whenever I want that, I will recruit them and use them, right? The other possibility for me is it's a post-germinal center lymphocyte. So first I'll have lymphocyte. They'll become a lymphoplasmacytic cell. They'll become plasmacytic cell. Right? This is what is going to happen, right? So plasma cells should produce immunoglobulin. If they have to produce immunoglobulin, am I right in saying that the transcriptional suppressors should be absent there? The transcriptional suppressors, absent or present? They should be absent. If they are present, it cannot produce immunoglobulin, it cannot produce antibody, right? So once they come outside, what will happen is my BCL6 will be negative, CD10 will be negative. In other words, I will have a transcriptional activator. The activator here, what I am worried about is an activator called as MUM1. MUM1 will be positive here, right? I have a transcriptional activator that becomes positive and the transcriptional suppressor becomes negative. This will activate my plasma cell to produce antibody. It's a newly formed plasma cell. A newly formed plasma cell will produce IgM or IgG. Can produce only IgM, right? The reason why they can produce only IgM is the surface of the lymphocyte has IgM. So the immediately available plasma cell will be IgM only, right? It has to produce only 1%. It will produce IgM only. But my body says that, see, IgM alone is not enough for me. I need IgG also. For IgG production, I need help of one more cell. What is the other cell? I need one more cell that will help me to produce IgG as well. I'm sure you know that. I need T helper cell, right? Only with the help of T helper cell, I can class switch and I can produce IgG. So now this entire thing happens in the post-germinal center, which means can I say outside the follicle? Outside the follicle, can I interact with the T lymphocytes? I can interact, right? So as IgM here, they interact, the IgM producing plasma cell, they interact with my T cells, and what they're going to produce is they class switch to produce IgG secreting plasma cells. But now I have a problem here. One of the major problem is I have created an IgG producing plasma cells. Okay, it's okay, Amir. I have created an IgG producing plasma cells. Can they proliferate in a lymph node or not? Lymph node, do they have growth factors? They don't have growth factors. They cannot proliferate in a lymph node. Where do you think all the hematolymphoid cells can proliferate a lot? Because I need this plasma cell to become 1000 or 10,000 so that I can have good amount of immunoglobulin. The only person which helps in proliferation is bone marrow. So this IgG secreting plasma cell will be taken to my bone marrow. Should I have someone to guide to the bone marrow? I need. So when a cell becomes plasma cell, it will start expressing two molecules, CD38 and CD138. Both of them have very specific function. Fine. Thymus will not be there in adult, so I'm going to go to bone marrow, right? So CD38 here is an homing cell. Homing in the sense, whatever cell is CD38 positive, it will automatically go to the bone marrow. So this IgG secreting plasma cell will be dragged to the bone marrow. So once it goes to the bone marrow, and let's assume this is my bone marrow. Fine. Can I say that in the bone marrow, the amount of blood flow will be very fast? If a cell is not adhered to something, it will be flushed away, right? So once with the help of CD38, the plasma cell comes to my bone marrow, they have to get stuck to the stroma. So what they do is, these are my plasma cells, they have my CD138, this is my anchor. So this CD138 are anchors. It anchors to my bone marrow, right? It just goes and puts binds like an anchor, anchors to my bone marrow. It's going to anchor to the bone marrow stroma. Whenever I disturb the bone marrow stroma, am I right in saying that they will release growth factors? I had a fracture. The fracture produced growth factor because stroma was disturbed, right? So this anchor will disturb the stroma. When the stroma is disturbed, They produce growth factors. Every growth factor in my life, they act in a paracrine fashion or an endocrine fashion. I'm having a growth factor here. I broke a bone here. The bone healing will happen only here. It cannot happen here, right? So everything will act in the paracrine fashion only. So can I say whatever multiplies the plasma cell will be present only in this area? It will multiply and produce my... I'll come to the Debraj. So it will multiply and will produce my antibodies. Fine. Okay, it's a very good thing. See, it's not about the trabecular meshwork. See, when I have trabeculae, my blood is flowing. I put in a trabeculae inside. When I put in a trabeculae inside, will the blood flow become more turbulent? It becomes more turbulent, right? The turbulence, I need an anchor for sure. If there's no anchor, they get lost. Fine. So it happens only in the paracrine fashion. So it happens in the paracrine fashion. All the plasma cells multiply here and produce my IgG, good amount of IgG for me to kill my streptococcus. So to produce one antibody, I need so many things, right? And so many things involved here. So if I know the normal B cells journey, the abnormality is really a piece of cake. It's very simple for me to understand it, right? So just have a quick look about whatever we saw after exposed to a pathogenic antigen. I'm just going to have a quick look again. It's a macrophage. My B cell got exposed to my streptococcal antigen, came inside. The macrophage in the subcapsular sinus gave the processed antigen to my T cell and they found it is pathogenic. Once they found it is pathogenic, they knocked off CD5. Once they bound to an antigen, CD23 was knocked off. Once 23 is knocked off, they enter my inner mantle zone. CD5 is knocked off, they enter my germinal center. Once they came into germinal center, the first stage I'm going to call it centroblast. The main function of centroblast here is I should produce multiple possible clones for all the epitopes of the streptococcus. I gave an example of 5 clones. I'm producing 5 clones. Of that, 4 clones should die. If 4 clones should die, BCL2 should be absent. This is anti-apoptotic. And if they are going to have multiple clone possibility, I will definitely have mutations. I should suppress P53. If P53 is not suppressed, I can never try out the possibilities, right? So these two guys will suppress P53. It's a very high proliferation because it's blast. So I need MYC antigen should be overexpressed in this place, right? So once that happens, I have selected one possible clone for me. That clone alone will be pushed to the second lineage called as Centroside. Centroside is a mature cell. Whenever any cell in the WBC matures, it becomes folded and will be disappearing, right? So it became folded. So from this where your follicular lymphoma as well as your NLPHL comes. So the nuclear infolding of popcorn cell is because of the centrocytes infolding, that's all. So this clone, it should persist because that's my best clone. It's the best match. So I turn on BCL2, I will then say them don't die. But they should not produce antibody. They'll produce antibody only they come outside when they become plasma cells. So I have the same suppressor which will suppress my antibody production also, right? So once they come out to the post-germinal center cell, I have few rules. One is memory, goes outside and stores in the marginal zone as CD43 positive memory B cells. 43 gives me a longer life, that's all. Again, it goes my lymphocytes, becomes lymphoplasmacytes, becomes a plasma cell. The immediate plasma cell which can produce, it's a very short-lived plasma cell. Produces IgM because that's on the surface. I need to class switch and to an IgG positive plasma cell which will have CD38, 138. The 38 will home it to bone marrow. Once it goes to the bone marrow, 138 is an anchor. It disturbs the stroma, produces growth factor, divides and produces good amount of IgG to destroy my streptococcus. Clear? Is that clear? So because if this is clear, for me, there are many things which I can extrapolate from this. If I know normal, abnormality is definitely simple. Now let's look at lymphomas. So my main problem of lymphoma is I really worry about and I struggle where they are originating from. That's my first problem. Second, I don't know what are the CD markers. That's my second problem. Now I know everything. When you know normal, you will know abnormality. Fine. Let's look at the abnormality. Looking at the abnormality will make it even more better, right? Let's take CLL. Let's take mantle. These two are pre-germinal center neoplasms, right? CLL and mantle. CLL comes from my naive B cell. Mantle comes from my inner mantle zone. Fine. CLL is going to come from a naive B cell. A naive B cell Can I say that they will be 23 positive and 5 positive? We saw a naive B cell, yes or no? The origin is naive B cell. 5 positive, 23 positive. I want you to answer here. This makes us even more better and confident. It's okay if you make mistakes, but I want you to answer. CLL will be CD5 positive, CD23 positive. Because a naive B cell had both of them, right? Yes, great. It's a B cell neoplasm, so I'm not taking CD20 and CD19. That is definitely there. Mantle cell lymphoma, the origin is from the inner mantle zone. It's not the outer mantle zone. It's an inner mantle zone. When I say it's an inner mantle zone, when a cell was capable of entering the inner mantle zone, when which CD marker was lost? When 23 was lost, right? Only when 23 was lost, they came into an inner mantle zone. Was 5 present in the inner mantle zone? It was, right? So mantle cell lymphoma marker will be CD5 positive, CD23 negative, because only when that's lost, it came inside. And when it came inside, we turned on one more gene. What is the gene? We turned on a gene which is cyclin D1. If you remember mantle cell lymphoma, these are the property of a mantle cell, right? Here is mantle cell lymphoma. What I have is increased expression of cyclin D1. When I have more cyclin D1, I'm going to cause a lymphoma. Clear? So I know the profile. I know exactly the profile. I know exactly the CD marker because I know what I am dealing with. Fine. Then from my inner mantle zone, let's assume it went into my germinal center. Once it goes to my germinal center, the centroblast lineage, right? From the centroblast lineage is where I had Burkitt's lymphoma. So my microscopy also looks the same. Burkitt's microscopy will have a high NC ratio, lots of cell death. That's why we had starry sky appearance, right? Because Burkitt's lymphoma will be BCL2 negative, because centroblast is BCL2 negative, right? Burkitt's lymphoma IHC will be, I'll write the IHC, you're going to say which will be positive and negative. 5, 23, BCL6, CD10, MYC, BCL2. So I wanted to comment on each and everything here. I have written all the possible markers. It's coming from centroblast lineage. Will it be 5 positive? No, because 5 only when it is gone, it will enter the germinal center. 23 negative, yes. BCL6 positive, transcriptional suppressor. CD10 positive, transcriptional suppressor. MYC positive, because that helps in the proliferation. That's why Burkitt is a very, very aggressive neoplasm, right? BCL2 negative, because no apoptosis, right? Anti-apoptotic factor should not be there because apoptosis should happen. Because the apoptosis is only, I have the tumor lysis syndrome in Burkitt's. I have the starry sky appearance in Burkitt's. So I know the entire profile here. My only goal is to understand and learn this profile with normal physiology. When I know normal, abnormality is a piece of cake, right? Let's go to the next one, Centroside. The lymphoma which comes from Centroside is follicular lymphoma. Follicular lymphoma obviously will be 19 positive, 20 positive. I am not writing 19, 20 for anything because 19, 20 is positive consistently. Right? We'll leave that, fine. Second, the main important thing for me here is it is from Centrosite. So what do you think will happen to BCL2? It will be positive, right? It's from germinal center, 10 positive, BCL6 positive. What do you think will happen to MYC? Negative. Because once it comes to Centrosite, the role is to maintain the population, not to proliferate much. So MYC becomes negative. So with this understanding, can I say that follicular lymphoma is a low-grade lymphoma? It has to be a low-grade lymphoma, right? MYC is negative, so it has to be a low-grade lymphoma, right? It is a low-grade lymphoma. Again, I know everything about the disease, not just the disease, the prognosis, the etiology also I know. Follicular lymphoma, my problem is there is more BCL2. There's a translocation between 14 and 18, where 18 is BCL2 chromosome, right? It increases, so it doesn't die for a longer time. I'm going to have the problem, right? I know about follicular lymphoma. We know about CLL, mantle, Burkitt, follicular, right? We'll go still further. We'll go to marginal zone lymphoma. Marginal zone, or I call them one maltoma, right? Most of the maltomas are marginal zone lymphomas. Marginal zone is where I had the memory B cell. So my marker profile is simple. There'll be 19 positive, there'll be 20 positive, right? That's one for sure. One more thing for me is what was making them live for a longer time is 43. When 43 is positive, I call it a marginal zone lymphoma or a maltoma originating from memory B cell. Now let's go to the etiology of the maltoma. See, understanding medicine gives us kicks. Really, it gives us kicks. Can I say that a marginal zone cell or a memory B cell goes there and stays there in the marginal zone silently? Yes, they don't do anything else. They just stay there silently, right? Whenever I have the secondary reinfection, I'll go and call them back. Yes, that's a normal function, so that I can have a heightened response. So I'm having a cancer from that. So when do you think I'll have a cancer from that? I go and call them again and again and again. Every 1 month I go and call them. Once I go and call them, they'll proliferate, goes back dormant again. Go and call them, they proliferate, goes back dormant again. So a recurrent activation of the marginal zone is a risk factor for marginal zone lymphoma. Yes? Is that correct? That is correct, right? So if that is correct, wherever you read maltomas, it will be chronic process. Chronic H. pylori gastritis can result in maltoma. Autoimmune disorder, Hashimoto's thyroiditis, again and again and again and again happening, will result in maltoma. Sjogren's syndrome, again and again I go and disturb my memory B cell, will result in maltoma. Anything when it's chronic inflammation repeated will result in maltoma, right? So maltoma will happen when there is a repeated infection. A repeated stimuli can result in a maltoma, right? And I can know about the entire disease process, right? Not only that, we'll come to plasma cell also. Plasma cell, when it came to the post-germinal center, I'm just going back once first to understand it. Here, can I say that a tumor coming from this place will cause an myeloma when it's a perfect plasma cell, right? As I said that a myeloma cannot proliferate in a lymph node, it has to go to the bone marrow. So only I call it a plasma cell myeloma. Myel is bone marrow. But if I'm going to have a neoplasm coming from this stage, neither lymphocyte nor plasma cell, in between, this disease, if you remember, we call them a disease called as Waldenstrom's macroglobulinemia. Do you remember them? You must have heard about this disease. Waldenstrom's will have and should have lymphadenopathy. Myeloma will not have lymphadenopathy because they'll have these two guys. These two guys will pick them up and take them to my bone marrow. Okay? They will definitely take them to the bone marrow. On the other hand, if you remember Waldenstrom's macroglobulinemia or this plasma cell, what are they capable of secreting? IgM or IgG? What are they capable of secreting? IgM or IgG? They're capable of secreting IgM, right? They're immediate. If you remember Waldenstrom, they will secrete IgM, so you'll have paraproteinemia, your hyperviscosity syndrome. It's IgM secreting lymphoplasmatic lymphoma. I call them Waldenstrom's, that's all. It originates from this area. So I know from which area whatever originates. If whatever I read is correct, my symptoms will perfectly match. When you take myeloma, it's a neoplastic plasma cell. Can I say that a neoplastic plasma cell will also do the same thing? It will go and disturb my stroma and it will proliferate, yes? So can I say that it also will proliferate in groups only? They will secrete growth factors in the paracrine fashion. They should proliferate only in the form of groups, yes or no? Yes. So can I extrapolate this to, I'm sure you must have read this, a radiological appearance of punched out lesion in skull. When you have skull here, it doesn't destroy everywhere. It'll destroy here, it'll destroy here, it'll destroy here. It'll go and punch out. It'll go and take them, it'll go and take them, right? Because of paracrine stimulation. No other disease has this, because no other disease has CD138. When any disease has CD138, it'll go and anchor, it'll go and destroy, right? Punched out lesion is almost diagnostic of an myeloma, fine? Again, I need to know normal. So once I know normal, abnormality is definitely easy, right? So this is about a normal B cells journey. Okay? This might be new for you, for some of you guys at least. I want you to go back, read this again. If you read this, you will never have a confusion again in B cell CD markers. See, as in, say, always used to say that I am not a mnemonic person. I am not so comfortable with mnemonics. One thing, I cannot create mnemonics. There are multiple mnemonics for CD markers, but I would say that going scientific basis, going the normal, and learning the abnormality makes me more confident. If you are that person who doesn't want to memorize, who want to understand with a reasoning, then this will be the best way to learn CD markers, right? Go back and read the Basal Journey again. If you have any doubt, you can ask me at any point of time in the Telegram group or on Instagram. Fine? Okay, that's all for today's. Any doubts? No doubts? Okay. It's no doubt, we'll call it off a day. Okay. Fine. Thank you for your time. See you soon tomorrow at 5 p.m. Maybe I'll see a little bit about the rest of WBC. We'll go have a look. And just an update for you again to end with. There will be 4 sessions here. Yeah, that's my problem as well, Devraj. Right? There'll be 4 sessions here. And tomorrow will be the 4th session. After that, you'll have questions, maybe based on the session or something bit random. Please have a look at them, and if you win any of the prizes, do share it with me. Fine. Thank you for your time. Bye bye. See you soon. Depriya, maybe something about leukemias. We'll discuss more tomorrow at 5 p.m. regarding leukemias. ALP in the sense? Devraj, can you expand ALP? Alport syndrome? I don't know what does ALP mean. If you meant app, I will upload on the Telegram group, right? If you're in the Telegram group, I'll put all the special classes, whatever's happening in the app, I'll just put it there. Fine. Okay. Okay. Today nothing. So we'll see tomorrow. Fine. Thank you. Thank you for your time.